So while that's loading up, what we'll do is all of the four of us as part of this team are going to talk about different sections. So we'll introduce ourselves as we talk about our specific bits. But um, I'm going first. So I'm Lee Alexander. I'm an improvement facilitator. So I'm work within the quality improvement team at Sheffield. So I work alongside Forest Close to help facilitate some of the great conversations they've been having. Can you see that now?
Yeah, we've got that up on the screens.
Okay, we'll kick off. So as the title suggests, we're going to talk about improving sexual safety on Forest Close. So this presentation, as you'd expect, we're going to talk about the changes, the progress, and the outcomes that the team have made. But we're also going to reflect on the process and the conditions which the team have created, which have allowed these changes to happen. So just before we move on, I'd like you to keep this statement in mind as we go through the presentation. So when thinking about sustainable change, the process is as, if not more important than the change ideas. And this process needs to be one of ownership, co-production and learning. And what we find is when conditions allow this to happen, we can get meaningful and sustainable change in the shortest time possible. And we'll challenge that often heard perception of quality improvement, and it takes a long time. So to build on that, I'm just going to frame the journey in terms of where we're at. So we had the CQC report in 2018, so we know it's a long-standing challenge, but we know it precedes 2018. This is an issue as old as time itself, and it's a very emotive one, as we've touched on already today. And then we've got the National Collaborative that started towards the end of 2019, but actually Forest Close didn't join the collaborative until December 2020. So as we go through this, hold in your minds that we're very much still at on the early stages of our journey. But what it does show is that when the conditions allow and the team are unable to work on this, you can get some really meaningful change in a relatively short period of time. And on reflection, I think starting in December 2020 wasn't a disadvantage because we were fortunate enough to be able to access all of the learning that came before us. And I can't compliment this programme enough for generating the discussions that we've had, and just hearing the presentations such as the one from Julie today is just really helpful. So that's kind of like the framing of it. So my final slide I'm going to talk about is defining and scoping this work. So with such a long-standing and emotive topic, sometimes it's just really difficult to know where to start. So what we did on our first meeting was with the core group of people, we got together, sat around the table, and we basically asked a question. So we asked everybody, what does sexual safety on the ward mean to you, and what do you want to get out of this work? So we gave everybody 5 or 10 minutes just to think and gather their thoughts, and then we went around the table and heard from everybody. And it wasn't about having a discussion, it was about listening to what this meant to people. And out of everything we did, this was probably one of the most is that a message? This is probably one of the most important parts of the whole journey because it really set us on the right path. And what came out of this was, by answering that question, the team started to develop a sense of ownership about what this topic means, and allow them to connect to the topic. So anything we work on from here on in will connect with what this work means to them. But also, with such an emotive topic, it's really important to understand people's feelings about this. Do they feel it's something that's important that we work on? Is it something that people feel anxious about? Where are they on that journey of feeling in a position to start making changes against this? And what came out of all of these discussions was we started to establish and broaden our scope and start to shape some really clear aims with this work. So before I started on this work, I was quite naive to the whole topic, and the frame of reference that I heard sexual safety talks in was reduction in assaults and sexual safety incidents, whereas actually by hearing what this means to other people, you start to broaden what it means. So it's about seeing sexual health and safety is an important part in people's recovery as everything else we do. people saying it's about supporting our service users to live safe and meaningful lives around sexual safety in relationships. It's about helping people to navigate relationships when they progress from the ward, and how to navigate the complexity of things like social media, understanding vulnerability, coercion, and things like that. So it became much broader than this narrow lens of reducing incidents. So I'm going to move on to Michelle, who's going to talk a little bit more. You're on mute, Michelle. Michelle, you're on mute.
Thanks. Okay, so I'm Michelle. I'm one of the occupational therapists at Forest Close. So basically what we did there, we kind of put together a survey, because once we understood what the aims were and the scope of the work, we needed to know actually what was happening across Forest Close in relation to sexual safety. And we wanted to ask, you know, how confident did people feel about talking about sexual safety? What kind of conversations were they having with the clients? You know, did they feel did it feel okay to talk about this subject? And what it meant to staff, what they wanted to get out of the work. So we put out these questionnaires. We got a really, really good response, actually. I mean, it needed a bit of pushing a couple of times, but we did get a really good response. We got over 60 responses to our questionnaire, and that kind of gave us, well, that was just so useful, because it gave us such a better understanding of how people felt. And one of the main things that came out of that was that confidence was the biggest factor. And there was four themes that underpinned that, and it was like knowing what to say and what the expectations were. You know, feeling, oh, I don't know if I can really talk about this. Am I opening up a can of worms? What do I do with this? Where do I go with it? You know, how do you introduce and start a discussion about sexual safety with your clients? It's just a very emotive subject. And it was dependent on, them conversations were dependent on the kind of the relationship between the staff, what kind of relationship they had, how kind of therapeutic it was, gender kind of differences and stuff like that, and also how knowledgeable and how experienced the staff felt. You know, all of these things were like kind of that was all the stuff that came out from that survey. It kind of gave us a really good insight. So we found like the conversations were wide-ranging. So somebody approaching discharge might want advice about contraception, or you know, how to start a relationship, or how to think about kind of safety in the bigger world when they were moving on. And then there was other things like that would come up for people, like previous sexual traumas. So when we're trying to cover all this massive range of experiences and our own kind of attitudes and some of our own maybe hang-ups and beliefs, you could see why it was going to be difficult. But despite all of this, you know, and like people's confidence, that, as we've said, we've identified that was a big factor. There was everybody felt it was really, really important. And there was absolutely kind of I felt like there was a real dedication that the staff wanted things to change, and they did want to start addressing this. But the difficulty was they didn't quite know how to do that. What do we do from here on? So putting getting the information from that, I guess, we knew like that we had enough now to go on to the next bit. What do we do from here? Well, we have to start looking at training. We have to kind of like start looking at how do we get past this? Because if we want people to feel more confident, then how do we do that? And I think really for that, I mean, I'm going to hand you over to my next colleague, Juliet, who she'll tell you about the next part of the journey.
Okay.
So I'll just turn this round, and there you go.
Hi.
Thank you, Juliet.
You're welcome. Thank you, Michelle. So, hi, I'm Juliet Miller, Senior Practitioner at Forest Close. So, as Michelle's already mentioned, we decided that what we wanted to do was that we needed to kind of look at the environment and create ideas of what we wanted that environment to look like, so that, you know, talking about sex and sexual safety can be normalised. We also, you know, wanted to look at the opportunity and create ideas for opportunities for the conversations to take place. And capability, we wanted to look at ideas to support colleagues in developing the confidence and experiences, and, you know, and how to approach and to look at their approaches. So as we gained more of an understanding of what work we needed to do, we identified 3 areas that we had to address in order to be successful. So we were clear that we needed change ideas that would help to create an environment where these conversations around sexual safety, sexual health and sex were normalised. And we wanted people not to be shocked as well, or taken aback if the subject was raised or discussed. So we looked at the capability, and from the questionnaires and the surveys that we did with the staff team, we were able to take out from that the topics that, you know, the staff felt that they needed to help themselves build their confidence and understanding around sexual safety and sexual health. And as you can see there, I'll not go through it all, but, you know, we've got the trauma awareness, trauma sensitivity, and talking about sex and safety. So then we looked at opportunity. You know, we realised that we needed to create these opportunities. It's, you know, talking about sex, it's a very, very sensitive subject, and we wanted those conversations to be done in a safe environment, but also taking into consideration that each individual will be at different stages of their journey and their recovery. We found the most important strand that we needed to work on was the change idea to increase capability, confidence and experiences, you know, which would equip people to be able to have the required tools to be able to have these conversations. So in terms of increasing staff's capability, we knew that we couldn't move forward with the work that we wanted to do because we'd be putting our colleagues and our service users in vulnerable and difficult situations, because, you know, we wouldn't be equipped to have those discussions. So we looked at designing and planning. Are we on to the next one, designing and planning? Please.
You know,
yeah,
you covered all of this.
I've covered all of that. I'm just looking for Lee to move it forward. Oh, I missed a bit. So in terms of the environment, we talked about having information boards. We wanted to align a lot of the discussions that we were having within other groups, and we also incorporated anonymous boxes for the fortnightly questionnaires, people to actually, you know, pop their responses into that. In terms of the opportunity, I've gone through some of the group things that we've done, but what we also did was we incorporated a sexual health screening tool on admission, and that was incorporated into the physical health clinic. We also started using the DASH screening tool, and we've developed a sexual health and safety workbook that has a range of questions and a range of supportive things within that the service user can actually use. We use the PDSA approach as well. So, as I've said, we've incorporated the information boards, the groups, but what we found with such a long and complex and long-standing challenge, we actually anticipated they wouldn't get it right the first time. So in terms of the screening, the sexual health screening on admission and the follow-up, we used the first one as an example, and any kind of areas that we felt that we could have improved on, we'll use that, we'll review it and use that to kind of improve the actual screening tool. Okay. So, is there another slide?
Measures.
Okay, I think that's over to Julie. Thank you. I'm going to hand you over to Julie, our matron.
Thanks for
Matron.
That. Thanks for that. Hello, I'm Julie, and as Juliet just pointed out, I'm matron of our service, which is a new job title, which we're not actually quite comfortable with yet, I have to say. In terms of measurement, we considered it from 3 angles. With outcome measures, we're looking at confidence and the incidents that are recorded via our QI postcards, but also local repeats of the first survey as well. In relation to process measures, once we trialled an idea and we were happy with it, happy that it was effective, then we went on to our measures and we wanted to look that they were happening as planned. So we were looking at things, as Juliet said, percentages screened on admission, training rate, and then finally broadening people's understanding of sexual safety and what it actually means. And we may actually see an increase in our reports, especially in areas such as grooming and coercion, which people may not have recognised before. Obviously, as a team, we've dealt with incidents that have involved grooming and sexual coercion, but it's not something that is well known within the service user group. And getting people to talk about things and what makes them feel comfortable. They were the sorts of things that comfortable and uncomfortable. They were the sorts of things that we were trying to gain much more awareness of and confidence building. We're mindful of the balance measures. We consider that we might have some unintended outcomes, and they're the sorts of things that, as we were broadening this subject, we realised that things we might be sort of faced with things that some staff find uncomfortable or out of the depth to deal with. Currently we've got some a service user that's sort of talking about having a sexual relationship with another service user in another service, and that throws up lots of concerns. Just that's a relationship that's based on equal understanding. People have got the capacity to understand what that relationship's about. So those are the sorts of things that we've really, because we've talked about this, because we've got community meetings where this happens, these conversations happen, then we are faced with talking about things in a much more frank way, really, than previously we were. So that in itself can be challenging. So could I have the next slide? Okay, so the impact sharing and the growth. We wanted to check in with a wider team as to how they felt that this was progressing. And we did this via a further survey, and it showed us that 80% of the respondents felt that the training had increased their ability and their understanding of sexual safety. And they felt much more able to initiate conversations than they had previously. So we were equipping people with approaches which were applicable in practice. We also found that the sort of balance and focus was about right amongst all of the other measures, and that there were changes that were the change ideas were sufficient start in trying to achieve the improved sexual safety of service users within Forest Close. We're also sharing all our experiences within the wider trust, so that we have a obviously we meet with our acute wards and our forensic services, and we talk to them about the sexual safety work that we're doing. We've expanded our improvement efforts, and we're applying similar QI approaches to improving physical health, transfers from acute to rehab, and looking at how we improve our rehab pathway with our community colleagues. And I think that for me, key to this being a success was that we had an established team, an established leadership team. We had a real passion for this work. People are committed to it now. People are interested in it, and people tell us that, actually, when you first started, it seemed a little bit, boring. What's the relevance of that to us? Whereas now we're getting people who are really coming forward and wanting to learn more and to do more in terms of training. It's also enabled us to think about how we move it forward in terms of developing groups. As part of OT, Michelle's got some brilliant ideas about how we can support all our service users to have safe discussions within evening social groups, within other groups that are happening. Moving on, yeah. That's a massive thing, actually, moving on in relationships. And we've talked a lot about whether or not in the future we'd have sort of dating app for our service users. And, that's something that we may think about moving forward. And I think finally, we're also talking about doing some more work with carers, and what the discussions that Juliet and I have had are around the fact that carers often have not had a lot of education around working with service users with psychosis and or other issues. So in terms of validation, we felt that we might be able to sort of bring this into education for our relative support group, because they tend to be overprotective or overcritical and not allow people to grow as, well, not tend to, but there are quite a lot of our relatives and carers who tend to not have had any education around psychosis and how it impacts on people. So we felt that this might be another area that we could add to our relative support groups moving forward. So that's it from us.
Back to Lee.
Back to you, Lee.
Thanks, Julie. Right, so this is just our final slide. I'll be quick because it's good if we could get into a discussion and any questions. But so Juliet and Julie and Michelle, they've talked largely about the process that the team followed. So ultimately established the aims, developed their understanding, came up with the changes based on this, and then they've got measures to measure how they're progressing against these. So that's the process that they followed. But what's been absolutely central to the team's success with this is what I touched on at the start, so around these conditions. So when we think about the key to sustainable change, this graphic here nicely illustrates it. I won't go around all of the aspects, but the thing that the team really got right from the start was the top right-hand section of this. So thinking about the staffing. So they've had involvement across the MDT, they've focused on training, they've really understood people's behaviours and motivations around this emotive topic, but crucially there's been senior leaders within the team who've engaged with this, but also clinical leaders right across the MDT through nursing and OT and so on. So it's those conditions which have helped it to progress, and what they've done is they've met once a fortnight with the same group of people, and what you're able to do through that is build on conversations from one meeting to the next, and then evolve your shared understanding and build that momentum. So that's just been absolutely central to this work. And a similar team who tried to follow the same process but didn't have those conditions in place are nowhere near a similar position to what Forest Close find themselves in now. So that, hopefully that's been helpful. That's the end of the presentation. So I'll hand it over to Tom for the next section.
Thank you so much, Lee and Julie and Juliet and Michelle. Amazing work. We've spoken about that before, and really evident the leadership from all four of you, actually, three of you in the team, and then Lee. I know you're providing external support, external to the team, but from within the trust. Hopefully other people have got questions as well, but I just wanted to ask, and you touched on it at the end there, Lee, about the kind of conditions and the consistency, and I suppose what that's allowed is the depth of the work that's taken place over the last nearly a year. And you kind of talked about that they're the conditions needed for sustainability, really, in on this team. And I know that I think Julie talked earlier about promoting the work at Trustwide with other wards in the trust. And I just wondered how that's gone. I think you gave a hint to how it's gone right at the end there, Lee. But I just wondered how I'm just with an eye to the next item on the agenda. Have you had any success, or can you see kind of the beginnings of a movement across the trust to take your work, or are the teams struggling to do it?
Yeah, so the work that we've done is fed into this central trust-wide sexual safety group, and through that a lot of the other acute wards are part of those discussions. And what's been great is other wards have seen the progress that Forest Close have made and felt actually we'd like to progress in a similar vein. So there's a couple of the inpatient wards put themselves forward to start this journey similar to Forest Close, and it's not saying that they'll do exactly the same as Forest Close, but they'll follow the same process of getting your collective. What does sexual safety mean to an acute psychiatric ward as opposed to a rehab ward? Is get that collective aim, and then be clear about what that team's understanding is, and then come up with change ideas which will work in that environment. So the idea was to take the process that Forest Close followed and then replicate that with a different team. Where we tried to do that with two other teams in a similar period of about 5 months. There's one team who met 3 times over the 5 months, and each occasion it was different people in the room. And with the best will in the world and with the best ideas, that won't gain traction, and people won't feel a true sense of connection and ownership of where this is. So, and this isn't a criticism of any of the teams who struggle to do that, because we know we work in challenging times, recruitment and staffing vacancies coupled with a pandemic and all this. But I think that what's been really important with those teams is to think, actually, if we continue to progress as we are, we'll arrive at change ideas, but they'll never land and it won't be sustainable. So we've stopped and we've taken a breather, and we thought, okay, how do we get the engagement of the wider team? How do we get the leadership involved? So 2 wards are now, they're just about to start this month meeting together. So hopefully by combining their efforts, they'll be able to get a better attendance, better representation, and so on. So it's a constant challenge in the world of quality improvement. And I suppose the risk that I always find is when people have the perception that quality improvement takes forever or takes a long time, the process doesn't take long at all. It's the fact that the conditions don't allow it to progress. And like the example I use, I've had CBT in the past. If I'd only attended the first session and the 4th session, the outcome wouldn't be very good. Equally with quality improvement, if you only attend 2 sessions out of 6 months, the outcome won't be as good. So it's a crucial enabler which we spend a lot of time trying to think through.
Yeah, that is really interesting. Great answer, I think. So I guess if people are starting to think about how they spread work across the trust, I mean, we've had some good examples from Nottingham earlier, but spending the time getting those conditions right, getting the lead, making sure that the leadership are fully kind of, and a group of people, it can't really sit with one person, can it? I think in a team. So it's great to see, all 3 of you here, and possibly others in the team as well. I think one. I don't know if Juliet, you want to speak. Yeah.
That, like in support of what Lee's saying as well, is that it's having that protected time as well to be able to do this piece of work, this ongoing piece of work, but also having the commitment from the the same level of commitment from the leadership team as well, and ensuring that feeds down into each ward and across the trust as well when we're attending those fortnightly meetings. So, you know, it's having that protected time as well that's enabled us to do this.
Well, I think Leanne, one of the ward managers from Ward 1A, is on the chat today, and you know, all of the ward managers have been instrumental in making sure that this is followed through. So there are 3 wards here, so it is quite a big service, but each ward has basically owned this, pushed staff, pushed people to attend groups, made sure if things have dropped off that it's carried on. And I think it's that sense that we work together as a team that's really helped us to achieve what we've achieved so far, and we hope to go on and do more. You know, this is just the start, really.
That's brilliant. Thank you. Are there any other questions that people have? Amanda's asked if you've got the sexual health and safety workbook as a resource that people can use. Is that available?
Our sexual health and safety workbook, is it available?
Absolutely is. Sorry, I didn't hear the question.
Sorry.
Yes, it is available, and what I can do is I can add it to this group chats for, you know, to share with others.
That's brilliant. Thank you. And and we'll also then send it round after the meeting as well. We'll take it from the chat and send it around. That's brilliant. I suspect that there'll be a few people who might want to talk to you, well, and Julie from earlier after today's session. So hopefully you're open to that as well. Are there any other questions before we move on to the next session? I don't think so. Okay, well, thank you so much again, all of you.